Pennsylvania. He's done residency at Columbia, Pennsylvania, and New York. Not one fellowship, not two fellowships, 3 fellowships. His radiology fellowship at University of Texas, critical care fellowship at University of Florida, and clinical pharmacology fellowship at University of Health Sciences in Maryland. As you all know, he's very big on publications. His publications are looking at maybe more than 90 peer-reviewed journals, maybe more than 30-something abstracts, 4 or 5 is involved in books and chapters, and awards, and more than 20 awards. Like I said, he's a professor. He was a director of a program right when he started, 2015, I think, when he finished director of the practice. Right now he's involved in a lot of publications. He's an editor of many journals. He's involved in Journal of American College of Biology, American Journal of Medicine, American Journal of Medicine, and in the ACB. This is not
okay.
just, there's no limit to that.
That's more than enough. Okay. All right, thank you. Thank you. So this afternoon, we're going to be talking about cardiovascular risk stratification in HIV patients. This is my conflict statement. I have no conflicts of any type with the content of this talk. Most of you know I have written a book on faculty development. I do get author royalties on that, but that's about faculty development, and this is about cardiovascular disease. So we'll start with a case. 59-year-old white male who first contracted HIV 25 years ago is presently taking emtricitabine, tenofovir, raltegravir, darnavir, and thiamine pyridoxine. And by the way, I practiced those all last night. He's referred to determine his need for primary cardiovascular prevention. He smoked for 15 years, but stopped at the time of his HIV diagnosis. He has no history of cardiac disease or symptoms. He has hypertension for 15 years, controlled with salt restriction and ACE and diuretics. He exercises daily, at least 30 to 60 minutes. His father had an MI at age 54. His mother and 2 younger brothers are reportedly free of disease. His diet is rich in fruits and vegetables with little red meat or saturated fats. Okay. His only other relevant past medical history is chronic lung disease, for which he uses inhaled steroids and bronchodilators. His physical exam is normal blood pressure, normal BMI. His waist circumference is 35 inches. And he has a resting ECG that is normal except for a left axis deviation. So you have fasting labs from last week. Total cholesterol is 220, HDL is 38, triglycerides 260, LDL 129. Ratio is 5.8, creatinine and liver function studies are normal. CRP is 3.7, IL-6 is 2.0. His absolute CD4 count is 435 per microliter, and his viral load is undetectable. His HCV antibody is non-reactive, A1C is 4.9, fasting glucose is 88. Okay, everybody got a feel for this patient? So as the consultant asked to do this, what questions have to be addressed? Well, the first is, what is the best way to estimate this patient's 5 or 10-year risk for hard cardiovascular events? How would we do that? Second question, can these same tools be used to estimate his global cardiovascular risk, meaning all manifestations of cardiovascular disease, including asymptomatic or peripheral vascular disease? What additional facts or data besides what I've already given you would you need to best estimate these risks? And finally, should this patient be started on statin therapy? If so, which statin and what target dose? I apologize for this arrangement. Evidently, the table is stuck all the way up, and I'm 5'6", and it's 5'9", so I need to be over here. Okay, so we're going to be addressing these questions looking at 5 different areas. Why is cardiovascular prevention now an issue for HIV patients? Are traditional risk equations useful, and what is their comparative value for HIV patients? What additional cardiovascular risks do infected patients have? a look at some of the new cardiovascular risk models specifically for HIV patients, and then very briefly at the end, in the interest of time, we'll just touch on a couple of areas that are under present research. Anybody doesn't know this to be a fact at this point? If you're not, wait a couple of weeks. It'll catch up with you. So, where are we now? Well, a lot of diseases that used to be imminently fatal have now, through our treatments, become chronic manageable illnesses. We therefore have new patient populations that we didn't have 20 or 30 years ago, resulting from our therapeutic successes. And this is by no means a comprehensive list, but CML, certain types of breast cancer, even systolic heart failure used to be imminently fatal, and now they are managed chronically, and of course HIV infection. So let's start off with how long can you expect your HIV patients to live? Well, the models used always assume infection at age 20. This way the numbers are comparable between systems and between cohorts. And they report survival from that time of diagnosis. So in 1992, this was pretty poor. The median was about 10 to 12 years. This was before there were really any effective agents around. Of course, as a median, it meant a lot of patients lived a lot less than this. Between 92 and 96 was kind of a gray zone. New drugs that were effective were being developed and implemented, this almost doubling the expected lifespan over that short time. And then the last big cohort that's been, large time frame that's been reported shows 30 to 57 years from a 20-year-old diagnosis. So you put that 57 plus 20, we're looking at life expectancies of up to 77 years. Are there differences among HIV patients as far as how long they're expected to live? Well, sure. Male patients, approximately 62 years, with uninfected men, 77 years, so about a 15-year difference there. Women do a little better, but the difference is greater, almost, it's 18 years difference. It's also affected by race. People of color, about 58 years, while people self-identified as white, 72 years, so again, a very big difference there. And also the mode of infection. IV drug abusers have the lowest expected survival. That's probably related to comorbidities, and particularly to HCV. Now, this data was collected more than 10 years ago, so I expect this survival here will improve now that we have more effective treatments and even cures for HCV. But homosexual men had a life expectancy of about 7 years. So homosexual men with HIV, non-homosexual men with without HIV. So these patients are living about the same as uninfected patients. There is, by the way, I asked to have posted on D2L in the website a reference list. I think there are about 95 articles on that, and all the ones that I will reference here are on that, plus some additional ones. So CATI is the Canadian government site. It stands for Canadian AIDS Treatment Information Exchange. This also includes US patients in their epidemiologic data. So why do these HIV patients die now as opposed to how they died 30 years ago? Well, still about half die of HIV-related disease. The next 5 causes in decreasing frequency are shown here. We expect, again, the liver disease to drop as HCV is being treated more effectively. And from this database, cardiovascular disease was cause number 6, accounting for about 6.5% of the deaths. In another large investigational cohort, the DAD, data was collected over that same period, but this was published in 2008. They found, and this was 20 countries, Europe and Australia, found that atherosclerotic disease accounted for more than 9% of the deaths and was the 4th most common cause. So our patients with HIV are living longer, and the risk of dying cardiovascular disease is higher. These are websites. If you got the handout, they're all reproduced on the handout. If you didn't get it, you can get it on the way out, because nobody's going to remember these from the slide. But these web references will get you to online tools you can use where you just plug in your patient numbers and it will give you a risk. The Framingham score you've all heard of. The Brazilian Framingham is basically Framingham with aggravating factors, the renal risk score. The pooled cohort, which came out of American Heart in 2013. SCORE, which is from the European Society of Cardiology. PROCAM from the Prospective Cardiovascular Munster ongoing registry. RAMA-EGAT, and this is rarely used among our patients, but I put it up there because this is the only model that was developed and validated specifically in native-born Asian patients. It's the only one. And then the ASSIGN, which was out of the Scottish Heart Healthy study. So this is a comparison, just a brief comparison of them. After Framingham, the Brazilian modification added some of these additional risk factors. With any of one of those being present, identified the patient as high risk, regardless of what the other aspects of the Framingham risk score were. Reynolds is basically Framingham that adds family history and CRP level. The pooled cohort was the first to include race as a variable and also blood pressure treatment. So if your blood pressure was normal at the time you're doing this assessment, but it was only normal because you were on 3 drugs, that considerably increases your risk. The SCORE system was the first one, even though it was developed among Europeans, as soon as they tried it, it didn't work among Europeans, and they had to calibrate it for the individual countries in Europe. But this was the first attempt at using geography and presumably socioeconomic features in a model. PROCAM was the first that added triglycerides as an independent risk factor, the RAMA-EGAT waist circumference. So here we're looking at starting to include aspects related to metabolic syndrome. And finally, ASSIGN is not one you can really use on your patients because you need to have the Scottish postal code of where the patient lives and their Scottish index for multiple deprivations. Having said that, they do allow you to use median values for this so you can get a number, but it's not been validated outside of Scotland. The idea here, though, is to really incorporate psychosocial and socioeconomic risk factors for cardiovascular disease. So it's initially a notable effort. So in our patient, how did these scores do? Well, not a lot of consistency. Okay, there's something going on with colors, but basically the lighter colors up there, those systems put the patient in a moderate risk category, not particularly low or high. The red ones, which are 3 of them, the SCORE, the pooled cohort, and the Brazilian, all placed our patient in high risk. So you can see in this one HIV patient, there wasn't a lot of agreement. How do they perform overall for HIV patients? Well, they have variable agreement with each other. In general, the Framingham score is considered to place more patients in moderate and high-risk cohorts than either the PROCAM or the SCORE models, but less so than the pooled cohort. The pooled cohort was studied independently, showing basically moderate discrimination, but not influenced when HIV-related factors were tried to be forced into the equation. So not terribly accurate for the HIV cohort. There are no validation studies for ASSIGN, SCORE, or the Brazilian model in HIV patients. And the papers that are out there are essentially comparing risk estimates. Okay, they're taking one patient cohort and using several different systems and see how the numbers compare. There are few, if any, that tried to calibrate, meaning actually measure the events and compare predicted to observed, or to do intermodal validations along the same line, saying, well, which one actually predicted better, which had a better predictive score. And unfortunately for us, these systems tend to show most disparity between in HIV patients at the inflection points. So that is where at the point between low and moderate high risk, which, as no good deed goes unpunished, which is, by the way, what I should have titled this talk, is exactly where we need it to be accurate, because those are the points that we have to make treatment decisions. So why may they not work in HIV patients? Well, one is the age range is different. Infected patients are at risk for cardiovascular events as early as age 20, in some studies down to age 16. Whereas the other models really don't kick in until patients are not elevated validated at ages lower than 35 or 45. Also, the atherosclerotic disease itself is different in infected patients. There's a lot less calcification. The lesions are more symmetrical and is more of a medial disease with smooth muscle hypertrophy, a lot of interstitial tissue there, and it looks a lot more like transplant vasculopathy than it does traditional atherosclerotic plaque. But of course, another reason may be that there are additional contributing HIV-related factors. So, are the populations different? Well, this is from two, you can't see. This is French data using two HIV cohorts in France and comparing as controls to the inter-heart uninfected population. So the differences here are pretty profound. Age at first MI, if you have HIV infection, is under age 50 median. I've seen some as low as 46. Whereas it is anywhere from 6 to perhaps 15 or 20 years higher in non-infected patients. The next line is even more concerning. I don't know, yeah, this does work. The percent of patients whose first presentation of their atherosclerotic disease is an acute MI. That's 4 out of 5 infected patients will not present with a positive stress test or an abnormal EKG or atypical chest pain or even stable angina. Their first presentation is with an MI. Whereas that's only true for less than a quarter of non-infected patients. The overall MI incidence index for patient years is roughly 3.5 times that of uninfected patients. And the impact of increasing age, which we'll look at in more detail in a moment, is greater in infected versus non-infected patients. So clearly the patient populations are different related to cardiovascular disease risk. This is a study, Triant did a number of the clinical trials in this area, both retrospective and prospective. This was from a 2007 publication just looking at the relative risk of MI in their entire cohort. This was actually a combination of 3 or 4 different cohorts pooled together, and basically found that the relative risk of having infection versus not is about 1.75. So you're roughly 75% more likely to have an acute MI and if you have HIV infection. This is from a different cohort from Massachusetts, and this is comparing the rates, again, index per 1,000 patient years of MIs stratified by age categories. So you can see here, even in the very young group where events are rare, whether you're infected or not, it's still 5 times higher in the HIV positive group. When you get up to the ages where most of our existing risk systems have kicked in and are felt to be accurate, more than a doubling to non-infected patients. And by the time you get into prime MI range, 65 to 75, rates are increased significantly, and HIV patients are more than 3 times as likely to die of a heart attack. What other contributors might there be that further separate the populations in explaining why our traditional risk models are not effective in this patient? Well, it may be difference in traditional risk factors. It is possible that the traditional risk factors have a different impact on risk in HIV positive versus negative patients, or the frequency of the modifiable risks, such as lifestyle issues, may be higher in infected patients than uninfected patients. There are also issues related to the infection itself and the inflammatory response to that, measures of disease activity that seem to correlate with higher risk, and then the drugs we use to treat them, both drug classes, sometimes individual drugs, and also another variable that appears important is the duration of exposure to individual drugs or drug categories. Okay, so the traditional risk factors, we have the same 2 that are unmodifiable, age and family history, but the incidence of the modifiable ones is clearly different. Smoking rates are higher in the HIV positive population. Males typically, at least 50% of males included in the studies smoked, in some studies as high as 70%. And in another observational trial found that 3/4 of the MIs that occurred in infected patients, those patients had either a prior or current smoking history. So smoking is really, really important in HIV patients. They have a higher rate of hypertension, whether this is due to the disease, the treatment, or both. And some estimates go up to as high as a doubling of that risk rate. Higher rate of dyslipidemia, particularly in two areas. They have higher concentrations of the small, dense HDL, the LDL, the oxidized LDL, that contributes most directly to atherosclerosis development. And also in this metabolic syndrome type pattern of low HDL and higher triglycerides. And these all come together to give a much higher rate of frank metabolic syndrome. So, are the traditional risk factors more impactful? Do they have a greater effect on infected patients than uninfected patients? That's the first question. And here is a review, really more of a pooled data study, not a systematic review. It was published in Circulation almost 10 years ago. Used multiple papers, but estimated the impact either for presence or absence of a dichotomous variable or a degree of worsening of a continuous variable like an age a year older or an increase in relative increase in total cholesterol. And if we look at the numbers, and these are kind of ranges in HIV positive patient studies, they are pretty much in the same range as the general studies. Clearly they are near the top or the bottom of that range in some of them. And perhaps by this comparison, HDL may be a little bit less impactful than in non-infected patients, but overall, generally, it doesn't appear that just because you have that you have an HIV infection, that in fact your family history or your cholesterol level is more harmful to you than a very similar but uninfected patient. However, that was looking at age as a single continuous variable. When you start to break down the age and the effect of increasing age on rates of MIs, the impact of increasing range, especially when you get into the older populations, is significantly greater in HIV patients. There's more than a doubling, actually down to age 35 it's almost doubled, but more than a doubling in 55 to 64-year-olds and a quadruple risk in those over age 65. And you'll notice that those curves are getting wider as the age increases. So as our HIV patients are now falling into these higher age groups, no good deed goes unpunished, the risk of MI is also increasing out of proportion to their increase in age. What about metabolic abnormalities? There are a whole host of these. I won't go through them all, but probably the most contributory to atherosclerosis is the lipodystrophy that's seen in HIV patients. This is a combination of an increase in visceral fat that we see in general patients developing metabolic syndrome and insulin resistance, but also a decrease or loss of subcutaneous or peripheral fat. And in fact, it is that loss of peripheral fat when combined with the centripetal obesity that is actually the greatest risk patients. This is more commonly seen in patients receiving NRTI treatment. And if you can find uninfected patients and infected patients that have exactly the same fat distribution as described here, including the same waist to hip ratio, the risk is not very different. So in fact, the lipodystrophy is more influential for infected patients because of frequency. They are much more likely to have this fat maldistribution pattern. And we also know that this leads to insulin resistance, and some of this is due to the disease and some due to the treatments. This is from a nice review from the European Heart Journal of photographs of a patient with HIV-induced lipodystrophy. You'll notice the, let me see if I can get a pointer here, the obvious increase in abdominal girth, but accompanying that is loss of peripheral fat. You see more definition of muscles and bones, and it's particularly noticeable in the face, where all those areas that are usually rounded in a human face are not rounded. The sunken cheeks, prominence of the facial bones. So this is a combination of fat accumulation in the visceral pool and then loss of peripheral pool. And this is the highest risk manifestation of this in HIV patients. Okay, maybe due to the immune response that the traditional models don't account for. Well, there's a lot of evidence that HIV patients have evidence for endothelial activation and dysfunction. These are some of the molecules, particularly VCAM1, that are being studied in most interest now. And of course, endothelial dysfunction can lead to ischemia as well as progress traditional atherosclerosis. Coagulation system is activated in HIV patients, and these are some of the markers that have demonstrated that. And there are also, of course, markers of chronic inflammation and the disease activity that have been associated with the cardiovascular risk. This is a nice little cartoon from the same review article in European Heart, which kind of tries to give you a visual combination of these factors. So they put the metabolic factors together, the dyslipidemia, the lipodystrophy, insulin resistance all coming together and showing you some of the biomarkers that are altered in HIV patients. Here is evidence of coagulation disorders in this population that could contribute. Some of the measured factors in defining endothelial dysfunction, and of course the markers of chronic inflammation and viral activity. So all of these may be contributing to that higher risk and in one part or another explaining why the old systems are not predictive in HIV patients. So when we look at cardiovascular death and specifically, this study by Ford tried to look at the influence of various HIV-related factors on different causes of death. So in the upper left hand, they used a measure of immune suppression by a degree of decrease in peripheral CD4 count, viral activity in an actual viral load count above and below. This is dichotomous. Here's also dichotomous mode of exposure via IV drug use versus all others. And they define disease severity here as whether or not the patient had AIDS or had ever had AIDS. I think if they had AIDS, they had AIDS. So you can see the cardiovascular risk. In this model, the immune suppression didn't seem to increase cardiovascular risk significantly. However, notice that the upper legend for this is a 100-cell decrease in absolute CD4 count. This paper did not say what the baseline CD4 count was. So this could have been from 500 to 400, or it could have been from 300 to 200, and we don't know. The higher viral load clearly statistically increased risk of dying of cardiovascular disease. Certainly those that acquired the disease through IV drug use had a much higher cardiovascular mortality. But as you would expect, using AIDS, full-blown AIDS as a measure of disease severity, if you're going to be much more likely to die of AIDS if you have AIDS than if you don't have AIDS. And because you're only allowed to die of one thing in the epidemiologic world, that means all the other causes of death are less likely. So nothing unexpected there. And maybe the difference is because of the drugs that we use to treat them. Now, right off the bat, I want to get this very clear. The SMART study was the sentinel study, but there have been several others since then, proving that effective continuous viral suppression, meaning trying to keep the viral counts undetectable and maximize the CD4 counts, are the best things to do for your HIV patients. The SMART trial compared two different strategies, a continual, that they call viral suppression model, kind of more of what we do normally, particularly with the newer drugs at that time, compared to what they called a drug-sparing model. So they were trying to see if maybe less frequent, lower dose, fewer numbers of HIV drugs, and therefore getting fewer side effects from those drugs might be better for the patients. Well, it wasn't. The drugs, that was called an interrupted therapy or a drug-sparing therapy. Those patients had a 60% higher risk of overall mortality and a 50% higher risk of cardiovascular events. So, not treating their HIV is not an option. Okay, regardless of what anybody says about the drugs, that is not an option. But what else can these drugs do? Well, there are considerable data specifically about the protease inhibitors, although as a category, although there are some exceptions, that particularly using the older drugs, the rate of cardiovascular events increases about 16% per year of exposure, and it's fairly consistent, that number. That doesn't appear to change over time. NNRTIs lead to more dyslipidemia, which of course can lead to more atherosclerosis. The NRTIs accentuate that fat misdistribution syndrome that we saw earlier. and cumulative NRTI exposure is associated with an increasing rate of MIs. One drug I'll mention specifically, which will be very important in the latter part of this talk, is abacavir. For a long time, it got a very bad rap in the HIV studies and was considered to be an independent risk factor, just exposure, not even a time of exposure. As an independent contributor to cardiovascular disease, there was a very large, very powerful meta-analysis performed by the NIH and the FDA, published in 2012. It's the DING reference here. And now, officially, according to our government, abacavir is not an independent contributor to atherosclerotic disease in HIV patients. Okay, you can take that however you want to in the present political climate. How could the drugs be doing this? Well, some of them, and I'm not going to get into specifics right here, but they can induce or worsen the lipodystrophy that's seen, and promote and worsen atherogenic dyslipidemia, contribute to the entire insulin resistance syndrome, and very good markers for promoting endothelial dysfunction in and of themselves, even separate from what the HIV infection does. And by two markers that are generally held in cardiology to be accepted markers for endothelial dysfunction, meaning a drop in expressible nitric oxide synthesis and an increase both in the production and in the half-lives of oxyradicals. So they may be working by any of these events. This brings in, this study brought in the idea of time of exposure. The red line were the observed events. The blue line is what was predicted by then the Framingham risk score. And you'll notice that right after therapy started, the observed rates started to exceed what was predicted by Framingham. And as the years of treatment increased, both scores increased almost in parallel. So once this difference was established, it was maintained up to 4 years of treatment. Are these statistically significantly different? Well, unfortunately not, because the confidence intervals are so big on the event rate. But considering how tight they are on the prediction, I wouldn't be surprised if we had a larger N, more than 126 events, if in fact we would have found statistical significance here. Okay, this is a very comprehensive study by Bavinger. If you are really into this and treating a lot of HIV patients, it's worth looking at. His group brought together studies and did formal meta-analyses on studies that had acute MI as an endpoint. They compared them for individual drugs and also for the category of protease inhibitors down here, and quantitative, the probability and the confidence intervals based on the size of the study. You all know how these graphs are developed. This is not the kind of stuff you commit to memory, but if anybody's interested, that data is available. It's a +1 article available in the public sector. So, these poor patients have all these risks of cardiovascular disease. Well, why bother? Let's just treat them all. Right? Let's all treat them all. Hopefully, all of you know that's wrong. And that is primarily because of the risk of ART drug and statin interactions. Most of these are through CYP3A4 inhibition by the anti-HIV drugs, resulting in a decreased catabolism of the statin drugs and higher statin toxicity. Most of these that have been reported are not just muscle aches, but in fact myositis or muscle necrosis. But there are also some of an increase in chemical hepatitis associated with combinations with statins. Pravastatin has no CYP metabolism and therefore is not considered to be at any increased risk and can be used without dose limitation. Pitavastatin, a newer drug, has very little CYP metabolism and not in the subgroup of enzymes that the HIV drugs inhibit. But unfortunately, both of these drugs are considered low potency. Pitavastatin is much more potent than Prava, but it is a newer drug and has very few studies thus far in HIV-positive patients. So what does this mean? Well, the risk of treatment, particularly as the HIV-positive population ages, is greater than in untreated patients and uninfected patients. So treating everybody is not the right idea either. We do have one study on ezetimibe showing short-term safety. I believe this was 3 to 6 months of treatment. There was no new safety signal when ezetimibe was added to statins. We have no data yet on the PCSK9 inhibitors, but another article I recommend to you is this article by Gadella. This is a pharmacy practice article, and it basically goes through all of the cardiovascular drugs, including statins and fibrates, and potential interactions with antiretrovirals, retroviral drugs. It's comprehensive but very readable, very clear. It's written in English, and the graphs are actually interpretable. So another good place to go to if you're going to be involved in this, especially if you're treating the cardiovascular issues related in these patients. So as a result, you've all seen lots of tables from this. I pulled this off the FDA drug safety website about a week ago. This table was first posted in 2012, and it describes recommended changes in treatment or no changes in treatment for the various statins. This chart is specific for the protease inhibitors, so you've all seen these. Some are much more comprehensive, and this was from that same review in the European Heart Journal in 2014. And here they have quantified dose adjustments and drug selectors to include many of the individual antiretroviral drugs, all of the available statins, and all available fibrates. So this is a bit unusual, more comprehensive by including the fibrates. But there are lots of tables that you can find around about the different statins, interactions, and dose adjustments necessary. Okay, so they're living longer, they're having a lot more cardiovascular disease, they're more likely to die of it, they're going to get it younger. Their treatment that's keeping them alive longer is probably contributing somewhat. But we can't treat everybody because treatment's not particularly safe. So why don't we just not treat anybody, just treat them for their HIV and tell them to stop smoking, run more, and eat tofu. Well, that's because the treatments are efficacious. There are many studies on surrogate endpoints. They show reductions in circulating biomarkers. Statin studies have shown improvement in circulating cytokines, particularly some of the more worrisome that are more closely linked to cardiovascular disease, and reduction in total cholesterol. And this was from a large systematic review and meta-analysis where I think they had 16 studies, so no question that statins reduce total cholesterol, and we know that reduces risk in virtually all populations. We have the one study of ezetimibe, which when added to a statin further reduced LDL with no apparent increase in toxicity. Again, this was short term. But we also have some data on clinical endpoints. And in this trial, which was by Gilbert, another French trial, basically established a dose effect of statins to the degree of event reduction. And as you know, when you're looking at trying to predict causation, one of the relationships you look for is cause and effect, that a higher exposure or more drug leads to fewer events. And they basically graded exposure using the dose of drugs, statin given, the intensity of therapy, high versus moderate intensity, and also patient adherence. So they're all the things that could be related to getting the statin into the bloodstream, and then we're able to correlate that more statin in the bloodstream meant more reduction in events. So this is highly suggestive of causation. And hopefully we will get the final answer from this trial, the REPIEVE trial, that is using pitavastatin in a randomized controlled fashion, primarily in lower risk patients, which of course is the only ethical way to do it, because if they're higher risk, we probably should have them on treatment, but this will be placebo controlled. This study is still recruiting, and we won't have data on it probably till after 2020. So, they're at high risk for getting it, they're living longer, they're having more MIs, they're more likely to die of the infarcts and other cardiovascular diseases. They have lots of reasons, including the drugs that are getting, to increase that risk. We have a lot of markers that both the disease and the drugs treating that increase the risk. Treatment is dangerous, but it works. So what do we need? What do we need that we don't have? We need new risk prediction models. So we're not treating patients that don't need it, and we are treating patients that do. So there have been attempts to calibrate the traditional models like Framingham. These have all pretty much failed. And that has to do with the fact that calibration just means that the relationships are the same, but the observed events are numerically higher than the predicted events. So a calibration factor is basically a fudge factor. You either add it or multiply it to the risk, and it may be positive or negative. But that assumes that the relationship and the relative impact of the variables to each other within a patient population stays the same. And that, of course, is not known to be the case, and attempts at doing this with Framingham and some of the others have failed fairly miserably. The others have been small studies, virtually all retrospective, but many of them made assumptions that we now know that are not valid. So for example, one assumed that Framingham is absolutely accurate for HIV patients, which of course we know that's wrong. Many of these also failed because they were retrospective. They didn't have some things I think are pretty important, like they had no way of controlling or including in the model smoking history or family history or some other major risk factors. The data wasn't available because these were retrospective. They were taking data previously collected. But in my mind, that more or less invalidates all of the trials. And in fact, I think the rest of the world has also considered them invalid in that I did not find any models, with the exception of one, that have been reproduced or are advocated in HIV patients. But luckily, then came across the DAD study, and this stands for Data Collection on Adverse Effects of Anti-HIV Drugs. This data were published in 2009, and this was a HIV-only study. The equations were developed. This is the website where you can find the tool to use both DAD models. It's also on that handout that I gave you. It's a nice site because it also has Framingham accessible and pooled cohort, so you can use it for HIV and non-HIV patients if you want to, the different ones. The data collected to validate this model, the initial DAD study, was used patients from 20 countries, all in Europe and Australia, in 11 cohorts, a total of over 86,000 patient years. Now, the total DAD cohort was over 49,000 patients, but in this prospective observational design, they wanted to look at only primary risks. So they basically had to exclude anyone who already had had a cardiovascular event or had diagnosed cardiovascular disease, and they were excluded because they're only looking at first event prediction. Patients who have established disease now are virtually by everyone considered high risk by definition. You can't be any higher risk than already having the disease. So that's why fewer patients were used. In this cohort, much broader age range, 18 to 75, a quarter were female. Interestingly, 60% identified as white, but 30% failed to put down any self-identification of race. And I think this is an issue because we don't know if 90% of these patients were white or if 40% were racial or ethnic minorities. We just don't know. They had a very high smoking rate, again, close to 70% overall, and about 1 in 5 are IV drug users. They had pretty hard outcomes for the primary study: MI, stroke, revascularization, or cardiovascular death. Obviously, revascularization does have a little wiggle room in it, but it is considered most of the time to be included in hard vascular events. Their follow-up, however, was a median, of 4.8 years only. So therefore, this model could only predict 5-year risk rates. And they came up in breaking down relative risks using this pattern in yellow: low risk, less than 1% risk over 5 years, high risk at 5 to 10%, and actually identified a very high risk of those greater than 10% at 5 years, okay, not at 10 years. So there are 2 DAD equations, the full and the reduced model. The full model variables have both continuous and dichotomous components. The dichotomous variables are gender, previous smoker or present smoker, so there are 2 hits in there for relative to smoking history. Family history of cardiac disease, diabetes, and abacavir exposure. So any abacavir exposure in this model added to the risk. And the continuous variables of age, PI exposure, and RTI exposure, the CD4 count at the time that the risk is being estimated, as well as systolic blood pressure and total and HDL cholesterol. The reduced model basically takes the drug factors out, includes CD4 count and all of the more traditional factors, but protease inhibitor exposure, NRTI exposure, and any exposure to abacavir had been removed from the model. And both of these are available on that website, by the way. This is a comparison with Framingham, and a few things I'll point out here. So this was in the primary results study. The DAD cohort was from 188 clinics in 20 countries. The Framingham study was done in one town in Massachusetts. The amount of follow-up, however, was more than twice as long in Framingham as it was in DAD. Framingham tend to include some softer endpoints, such as a silent MI. And in these papers that included that as an endpoint, that meant that you had EKG evidence or echo evidence or nuclear perfusion evidence of an MI in the patient not having a history of an MI. Patients were not stress tested or cathed or anything to try to define that more clearly. And some differences in the coronary and cardiovascular definitions. Oops. All right, how are we doing this here? It's really hard to do this reaching up. And it's not working. Can't put this. Sorry. Daniel. Oh, okay, so we can go backwards and we can go forwards. This shows the validation with, again, ROC curves between DAD and Framingham in this study. And as you can see, the area under the receiver operator curves were virtually identical between DAD, Framingham, for both MIs and coronary heart disease by definition and cardiovascular disease by definition. Those are the first numbers are the AUCs, and the other is the standard deviation. But when these data were expressed as the predicted events to the actual measured events, so in other words, how much did each of these models either over or under predict compared to the real event rate, here's where the comparison starts to fall apart. For the MI diagnosis, Framingham predicted in about 15% more patients that they would have an MI than actually did. Framingham was, DAD predicted a few fewer than actually occurred. And if you look at it across the three lines, the DAD was pretty much right on. A number of 1.0 would be perfect prediction. So it tended to underestimate a tiny little bit, but that was very consistent pretty much regardless of what definition you used of heart disease. However, the difference between Framingham's overestimation and DAD's estimation gets worse as the definition gets more general. So here, more than a third more would be diagnosed as high risk for coronary heart disease, and more than 50% increase prediction error for the more general definition of cardiovascular disease. These are some studies that compared the DAD to various traditional models. I'm not going to go through this in detail, so I don't put you all to sleep, but just look at the author conclusions. In some of the studies, the conclusions were that some of these models underestimated or were only accurate at low risk. Others, that there was the amount of agreement overall with the DAD was relatively poor, no more than 75% agreement. Others found Framingham and Procam to underestimate the risk, and some found Procam to, or the Framinghams to overestimate and Procam to underestimate. The Edwards-Jackson study, the divergence was really astronomical. DAD identified less than 1% of patients at high risk, Framingham 9.9% of patients. So an awful lot of patients would have been treated if this was applied based on the Framingham score than the DAD score. So we got it, right? We got what we were looking for. We have the DAD model, and now we can use that. Well, remember the name of this lecture, no good deed goes unpunished. Let's compare them a little bit further. This was from an East European study which had some very good graphics that demonstrate some things. These are 4 systems used in their HIV positive cohort, and the red in the top graph identifies patients that would be determined in the high risk group. So the DAD predicted more patients than these other scores be high risk, therefore more patients would have been treated. When these were translated into whether or not treatment were recommended, that varied upon which treatment recommendation guideline you were using. Both European guidelines suggested far fewer patients, between 20 and 25%, than the AHA guidelines, the most recent ones we have in this country, which were predicted about 40% would have treatment indicated. And looking at it another way, this is from the same trial, and here they are comparing low versus high DAD scores, observed agreement with Framingham score and ASCVD, and I'll point out just a few things here. There was a lot of disagreement in the models. Between 1/3 and 1/4 of patients ended up with different risk rates or different risk predictions, comparing DAD to their individual models. Sometimes 1/3 of patients would not be seen as high risk, so this is the comparison of agreement for high risk patients. It was a little better, between 10 and 15% difference for low risk, but look at the kappa. Kappa is a statistic that estimates the degree of agreement between multiple observers looking at the same data. Okay, so in this case, the observer is which model was used. And for Framingham and score, it's less than 0.5. It's a little better with ASCVD, but still a great deal of disagreement in large proportions of the population. This study looked at it another way, and the light gray here is low risk, the dark gray is medium risk, is that visible? Yeah, and the black is high risk. And this looked at 4 models, the Framingham plus aggravating factors, ProCam and DAD. But when you translate this again into treatment, DAD predicted about 1/4 of the patients should be treated. Framingham said only 6% should be treated, and ProCam less than 2%. Enormous differences in treatment recommendations here. If you take those aggravating risk factors and apply the Brazilian model, almost twice as many. So even in these populations that were studied specifically, both the estimates and the number of patients recommended for treatment varied tremendously, almost to log levels in some. So let's look at our patient, the additional data he needed, which was one of the questions. His total protease exposure, protease inhibitor exposure was 8 years, NRTI exposure was 10. He had never received abacavir. So his 5-year DAD risk, full model, was 8.9%, well up into the high risk range, the very high risk range starting at 10%. Using the reduced model, taking the ART drugs out of the equation, was 6.4%, still in a high risk category. So this patient was started on pravastatin 40 milligrams. This patient was actually treated almost 3 years ago. This is based on a real patient. And pitavastatin was a new drug then. It was then and still is proprietary, so very expensive. And we did not have a lot of validating or safety data. So DAD's it. That's what we're going to use. High risk, treat with as potent drugs as we can get away with. Well, no good deed goes unpunished. There are problems with the DAD. The first is that the data is over 10 years old now. They stopped collection for this model validation in 2006. Second, the FDA has been pretty clear, and I agree with them, I've looked at this paper, that abacavir is not an independent risk factor. Well, that basically invalidates one of the major risk categories in the full model DAD equations. Also, they used only a European-Australian cohort. Now, since that time, the DAD cohort has been increased to include US patients and I think Argentinians and a few others. But the SCORE trial, the SCORE model was developed only in Europe, only for European countries, and still didn't work. Even within Europe, it had to have calibration factors for the individual countries. So it really makes you question whether or not another study that was all European or European ancestry patients could have the same extrapolation. And there have been limited actual validations, observed versus expected, in other HIV cohorts beyond the DAD population. Also, these equations have no input for race, and I think this is another major flaw in the DAD process. It only predicts 10-year risk, and technically, the treatment recommendations, both from European and American sources, recommend treatments based on 10-year, not 5-year risk. And the DAD, you'll find papers where they extrapolated those equations mathematically to 10-year risk. Those are interesting hypotheses. There's absolutely no data validating them except to the mathematicians. So I don't consider this extrapolation to be valid. And we don't even know yet if the DAD numbers in the actual equations are as valid in other HIV populations, say in South America or Asia or in Africa, because of the group that it was used to validate. So a lot of issues with this. And just for the sake of time, to try to improve this system or other systems that might help in the HIV patients, these are areas of research, and I've only included a few of the specific markers that are being looked at. There are those measuring disease activity, and I've listed the ones that are kind of hottest right now. That may change by the end of the week. HIV disease activity markers, inflammatory biomarkers, and coagulation activation system markers. And I'll just talk about these just as an example of two I'm interested in, are the inflammatory biomarkers. This is a results table from a systematic review I'm working on with Dr. Galotra, looking at the association of CRP with hard cardiovascular endpoints, and using just those two criteria that narrowed this enormous pool of studies down to only 5. You can notice that a lot of variables were not controlled for, and if you look in the last column, 2 found no statistically significant association between CRP and heart events. 3 did find a significant association, so almost right down the middle. In a similar paper, I'm working on with Dr. Patel, looking at IL-6. With those same limitations on included articles, we found only 3. Again, some things are controlled for that should figure into it, others were not, so there's not consistency there. There's also in both groups of studies not consistency in when the CRP or the IL-6 was drawn relative to when the event occurred, although some did try to control for large differences in that. But here also for IL-6, 1 study was not significant, 2 had a significant association. So no answers there. So in conclusion, and these are my conclusions, you should draw your own from the data presented. Of the available models, I believe the reduced DAD equation is the best we have at the moment for use in HIV-positive patients. The reduced model, why? Because of the change in the risk associated with the Bacavir exposure and the fact that those models were developed before some of the present HIV drugs that we're using today were actually around. Using other models is basically bad. They can overestimate, they can underestimate. You'll treat a lot of patients that don't need it. You'll miss treating patients that do need it. And they're not even inaccurate in a predictable way. So it's not that one overestimates, always overestimates, or underestimates. They can be haphazard depending on which cohort you're looking at. So in my opinion, the direction where this needs to go, saying this is a rapidly changing field, everything now is a rapidly changing field. But a different approach, the big data approach, basically using proteomics where you measure hundreds of proteins in thousands of patients and see which statistically fall out, and then correlating those with more detailed analysis of the antiretroviral drugs, including individual drugs, doses given, and durations of exposure, may ultimately produce the best model. And I'm hoping that we can go to something like this over the next couple of years and do a pilot study with our HIV population here to see if, in fact, significant results can be suggested in a small population. And thank you for your time. I'll be happy to take any questions. Nothing at all. Okay, thanks.